My name's Paul Oslington. I'm Professor of Economics and Dean of Business at Alpha Crucis College, which is an attempt to start the first private university since the new legislation made it possible some years ago. So we're a private Pentecostal start-up in Parramatta. So I left the university system 4 years ago to be part of this crazy plan. But the focus today is mental health. I'm here as chair of the organising committee of the conference and as vice president of the society. And this session was really the thing I was most passionate about in putting the conference program together. And I think it follows on really well from some of the things Carol was saying in the last session. Brings into sharper focus some of the issues she was raising. We all know mental health is a hugely significant issue for Australia. The small amount of work that's been done by economists, mostly commission studies, getting consultants to estimate the economic impact of mental health, really doesn't tell us much more than we already know, that it's a big problem. But the thing that I wanted to get at in this session was how the tools of economics can be deployed to make the mental health system work better. At the moment, and some of us on the panel have had family or personal experience of the mental health system. My own experience, family experience of the system, is that there's a lot of, almost always, good, well-trained people working in the system. I think there needs to be more resources devoted to it, but there's actually, a fair bit of money sloshing around the system at the moment. But the problem, it seems to me, is that the incentive structures mitigate against actually fixing people. Incentive structures are all directed towards lots of objectives, other than actually helping people to get better. So, and economics is the set of tools that can help us to understand why it is so broken and maybe come up with some constructive suggestions for fixing it. There's other ways that economics can contribute in this area, and Alan's talk, I think, will be a really significant moment for the discussion of mental health in Australia as someone who has who's a well-trained economist, who knows policy, but also knows the mental health system. Bringing us I think what's going to be a really significant address about the way that economics can contribute to diagnosing and fixing some of the problems. So the way we're going to run is that Alan, who's chair of the Mental Health Commission nationally, is going to speak for about 30 minutes. And then we've got a really excellent panel. And I'd just like to particularly acknowledge Alan and Frank Quinlan from Mental Health Australia, who are part of the early stages of this session. And their partnership, personally on behalf of their organisations with the society in mounting this session is really appreciated. So our panel will be Frank Quinlan, who's CEO of Mental Health Australia, Deborah Cobb-Clark, Professor of Economics at the University of Sydney, Dr. Jeremy Samet, a researcher from the Centre for Independent Studies, and Professor Richard Freeman from Harvard and LSE and NBR and Citizen of the World, I guess. So we're really, really pleased, Richard, that the only session at the conference. Now, Richard has been a keynote speaker at the Society's conferences in the past, and the only session where you'll get a chance to hear Richard on stage is the mental health session. So really pleased to have you part of it. Richard is visiting the Centre for Mental, I hope I get the name right, the Centre for Mental Health Economics at Macquarie University for a few weeks, I think. So that's the way we're going to operate. Alan will speak for 30 minutes. Respondents will have 8 minutes after that to reflect on Alan's presentation and maybe throw in a couple of brief reflections of their own. And then we've got half an hour or so for discussion after that. And my hope is that not just that these papers will, or Alan's address and the responses will stimulate a good discussion now, but it will also draw economists into this area. It was quite remarkable having a look around the literature. Now, it's not my area of research at all, but just how thin the research in Australia and overseas on the economics of the mental health system is. So a real opportunity for people doing PhDs, for people helping people decide what they'll do PhDs on, to do some interesting, for some smart people to do some interesting, worthwhile research on the economics of mental health. But anyway, that's enough from me. So I'll pass over to Professor Alan Fels, University of Melbourne and Chair of Mental Health Australia, the National Mental Health Commission, to talk to us about the economics of mental health. Alan.
Thanks very much, Paul, and I congratulate you on having this initiative and also to follow on from that great session from Carol Graham. And also, just to respond to one of your points about incentives, you're dead right. There are major incentive issues. Just to give you one, if I have a headache and I walk out the front door, I can immediately have 5 psychiatrists nearby or 50 psychologists attend to me. If I live in a poorer area of Melbourne and I go to a GP with a fairly serious mental health problem, that GP is not particularly likely to even bother trying to find a psychiatrist or psychologist because of their unavailability, and even worse in rural and remote areas. And that's because under the Medicare system, qualified medical practitioners simply go and collect their provider number, and then they can live wherever they want to, and they tend to live in better off areas. So that's just one incentive story, but there are heaps and heaps of others. And also on the question that you mentioned about research, I'm going to mention a few broad areas of research, but on the whole, there are really interesting research questions in the field of mental health. There are quite a few interesting ones in health, and they're kind of compounded and even more challenging and interesting in the field of mental health. Just to take one example, take treatment. Now, immediately one can recognise that in treatment, it's quite hard to assess quality, either the patient or third parties. And how do we deal with it? Basically, we're moving towards having DRG-based pricing, diagnosis-related group pricing, or activity-based funding. Now, that's based on the idea of, say, you've got a knee operation, then the government can assess the average cost of that, and if a hospital does 100 knee operations, it will get 100 times the average price of a knee operation to determine its funding. With mental health, however, there's huge uncertainty about, first of all, what's required, what would work, but also how costly it would be. Sometimes someone is in hospital for a day, sometimes for 6 months. And with that high amount of uncertainty, these pricing systems, which work okay in the rest of medicine, really lend themselves to all sorts of bad effects, including the temptations for skimping, for under-treatment by the providers. So that's just another example, but there are countless interesting research questions in this field. I'm going to kind of quickly run through the mental health story. So let me just begin with a couple of overview comments. Mental illness has a devastating effect on the lives of persons with mental illness and their families and carers. I want to talk today more about the economics of it. It costs 4% of GDP. There is much scope for greater investment and better policy, and arguably a 25% improvement over 10 years would yield a 1% gain, and the gains from the reform of mental health would dwarf most of the gains from the contemporary proposed economic reforms that we're forever talking about. And this is what Martin Wolf says: mental ill health, the developed world's most pressing problem. Given the economic cost to society, the costs of treatment would pay for themselves. So just a little bit about incidence. 1 in 5 of the population are affected by mental illness each year. That is, they need some kind of clinical treatment. And about half the population once in their lifetime. 3 to 4% of the population in Australia and everywhere have severe persistent mental illness, schizophrenia, bipolar. 15% on top of that have serious, less severe forms of mental illness, depression and anxiety at a level that requires treatment. There's also about 8 suicides a day in Australia, many linked with mental illness. And there's a little chart setting out the distribution of mental ill health in another way. I just mentioned that the numbers I have for severe episodic, severe and persistent, if you add the two up, the numbers right, there is at the moment quite a heated controversy about what those numbers should be in relation to the National Disability Investment Scheme. But about 700,000 people with severe and persistent mental illness who require high levels of support, both medical and social. Now, there are also significant issues for minority and individual groups. Mental illness outcomes for the Indigenous population are terrible. For the LGBTI population, very severe. Culturally and linguistically diverse, above average. Dual diagnosis, that is people with mental health and drug and alcohol abuse problems together. Many persons with intellectual or physical disability have significant mental illness problems as well. I just mentioned sport because it's always in the news. It's a prominent example of the fact that there are many, many occupations, especially stressful ones, with high rates of mental illness. And I'm forever, as chair of the NMHC, being invited to this group, the lawyers, the doctors, the construction workers, heaps of others who have all got quite significant mental health challenges. And indeed, there's a story of importance to be told about mental ill health for children, for adolescents, for middle-aged, for old, and for all classes of people. They require special consideration. A little bit about the costs. Now, a large number of people are affected by mental illness, so that means its economic cost is high and its duration is longer than for most illnesses. It strikes people most in their working years, can endure for many years or a lifetime, unlike many illnesses that just apply when you're young or very old. So that adds to the economic cost. The direct costs include medical treatment in hospitals, community mental health, cognitive therapy by psychologists and others, primary care with GPs, self-help, e-health is becoming more important, and pharmaceutical. And I just mentioned that pharmaceutical treatments are very important for severe mental illness, but important for moderate to severe mental illness, and sometimes has a role for mild mental illness. Now, the indirect costs, criminal behaviour and imprisonment, a working number is 50% of the prison population have principally got a mental health problem. A number of them seek it out as a form of accommodation. There is drug addiction, alcohol and drugs, There's substandard housing and homelessness. Again, a working number is about half the homeless are there with a significant mental health problem. Unemployment, disability pensions. They make above average use of the general health system, they have to. And there are major costs to carers and families. I just want to mention the costs of low participation in the workforce and also low on-the-job productivity. So in most countries, labour force participation by people, even with mild to moderate mental illness, is unduly low. And Australia, by OECD standards, is particularly low. We're in the bottom half of that 26, 28, whatever members. Carer participation is also low, and you'll see that is picked up in participation by older women is below what you would expect. And then for people with work, absenteeism and so-called presenteeism cause low on-the-job productivity, a matter of growing concern to employers, such that the BCA, ACCI, COSBOA, Mental Health Australia and others are involved in the Mentally Healthy Workplace Alliance, which tries to deal with some of these issues. But poor participation, poor on-the-job productivity has a high cost to the economy, foregone output. World Economic Forum estimates 1.75% of GDP. Just looking at Commonwealth spending, then there are state spending as well, but just taking 1 year that's readily available, 48% of the 10 billion is spent on disability support pension, 10 on hospitals, 10 on carer payments, Medicare and pharmaceutical, and only 12.5% on others. In other words, most spending of the Commonwealth is on failure, on the system having gone wrong, on people needing special treatment in hospitals or having to go onto the DSP. And state government spending exhibits a similar pattern, and only a small amount of spending is on prevention and early intervention. So there's a fundamental misallocation of resources problem going on in the field of mental health. Now, let me just briefly skate over causes. Genetic is a major factor. There is environmental, abuse, family violence, trauma, stress. There are socioeconomic factors, economic, poverty, prolonged unemployment, debt, living conditions, especially substandard accommodation and homelessness, which is the plight of very, very many people with significant mental illness, social isolation and stigma. There's also, I'll euphemistically call it lifestyle choices, that is drugs and alcohol. These factors, genetic, environmental, lifestyle choices, interact with one another, which is cause and effect. Is someone on drugs, is that causing mental illness? Or, as I see it, someone with a predisposition or actual mental illness is using drugs as a form of medical relief. But cause and effect issues are quite significant. So couple of consequences of policy note. If you look at my causes there on the left, and then you can immediately see the policy needs: health, social care, housing, education, criminal justice, employment, voluntary income and benefits, family and carers. Or if you want to think in budgetary terms, just looking at Commonwealth departments, health, social services, the old FAXIA, education, justice, business, and employment department, non-government organisation, social services department, and so on and so forth. And in fact, if you go around just Commonwealth agencies, most of them have got an interest: immigration, veterans affairs, agriculture, just everyone has some interest in this matter. Now, on policy, recovery is possible. And for much mild to moderate mental illness, a virtually complete recovery is possible if well treated and handled. For severe mental illness, much improvement can be made, restoring people to the best possible circumstances in their life. The term recovery is often misunderstood. It doesn't necessarily mean perfect cure. Rather, it means restoring people with mental illness to their best possible condition. That's a philosophy that drives mental health care. It has hope, and it indicates things can be done to better the lives of people with mental illness. I just want to mention that treasuries and so on shouldn't read recovery as meaning that everyone who's treated is going to be cured, and therefore all solutions and all spending should be temporary. Now, there's been a history of deinstitutionalisation that was necessary, but when it was done, it was not replaced by a comprehensive policy approach. So some of the current policy problems: stigma and discrimination exists on a significant scale in the community. It's probably somewhat improved in Australia in recent times, but there's a long way to go. Mental health is just not a high enough priority in the health system, nor in other areas of policy such as housing and employment. The system tends to respond too late, and that's largely because it doesn't invest enough, especially in prevention and early intervention. The system tends not to see the whole person. Health perspectives dominate, while socio-economic and environmental determinants play a lesser role. So that if someone goes into hospital and gets treated, fine. But then if they move out of the hospital and that night sleep under a bridge, they're likely to return to hospital quite quickly. We need a whole of life view of people, especially those at the severe end. Broadly, the system doesn't allocate and use resources terribly well. There is also a high level of unmet need linked with issues of access. The system of mental health is very fragmented and very difficult to navigate. There are, as I've already indicated, quite a few different sorts of needs for different sorts of people, and the treatments are not integrated, and the movement even between primary, secondary and tertiary care in medicine, starting with GPs or psychologists moving through, especially on the hospitals, that's also not terribly well integrated. There is limited choice and competition. People with actual experience of mental illness and their families have a quite poor experience of care, and there are major equity issues, both socio-economic and also geographic distribution of services. As I've already touched on, services are strongest in well-off parts of Australia. Now, some elements of reform, and there's really a very big agenda, but I'll touch on a few. Mental health needs to be a higher priority in the health sector and in general policy. There can't be health without mental health. There needs to be better public understanding and support. The approach needs to be more person-centred, to begin with their problems and needs, rather than supply-side or provider-centred. Recovery needs to be the guiding principle. There needs to be an investment approach, and there needs to be a whole-of-life, whole-of-person, whole-of-government approach. In other words, a person with mental illness needs a place to live, something to do, whether it's a job or, if they can't work, some kind of social connectedness or activity. They need, of course, health and psychosocial support, a connection to the community, removal of stigma and discrimination. And some other elements of reform are stepped care, that is, matching treatments to severity of illness. Some people have very mild mental illness and they need maybe a bit of guidance for self-help. They can also these days use e-health guides to get them started, and some people like to do that because they don't have to tell anyone they're mentally ill. At the other end of the spectrum, where there's severe mental illness, the 3 or 4% that I talked about, they have a very wide range of needs covering medical accommodation and so on. I'll come back to that in a moment. There's also much need for better integration, coordination, navigability of services, access for all in need, consumer and family involvement, and greater focus on and measurement of outcomes. Our Commission has been calling for a long time just to get some data on the subject. There's a massive data on what's spent, practically nothing on outcomes. Okay, so just a little bit more on step care. I won't take you through that in detail, but you could have a look at it. It's just about, it's kind of a pyramid where, you know, for very severe people, they have high-level needs, and I've set them out there. You may have trouble even reading it. Then there's another spectrum of low to moderate needs. And then finally, I put at the bottom for the whole population things that should be done on a population-wide basis, and that takes us into questions of mental health and well-being of the whole population. And then I've put on some numbers on the other side of the pyramid, but basically the idea is severe mental illness requires more attention and treatment. At the other end, much less so. And then there's some questions about the general population. Now, I just wanted to mention this integration question. System's hard to navigate, and in addition, there's often not a very well coordinated treatment. And for example, often people leaving hospitals are discharged into homelessness or substandard accommodation. Coordination and integration is required on housing and health, on education and employment and mental illness, on dual diagnosis. The treatment on the whole of people with drug problems is different from the treatment of mental health. And then to give you another really striking example is the treatment and integration of people with mental and physical health problems. Now, the data reveals that for people with schizophrenia, their life expectancy is about 20 years less than other members of the population, 14 to 23 years, according to the research. So the life expectancy of people with severe mental illness is worse than that of the Indigenous population, for example. And there are a number of causes of that: the medicine, the lifestyle of people with mental illness, but also a failure to coordinate treatment. The psychiatrists don't pay much attention to the visibly bad mental health, physical health of many of their patients. On the GP side, there's a lot of research showing the so-called overshadowing effect. That means that if I go to a GP and say I've got a sore back, I'm regarded as fine, I've got a sore back. If the GP knows that I've got a mental illness, that factor tends to overshadow the approach to that person's problem of physical illness. So we need to get the treatment of these two things much better integrated. I've already mentioned this question of investment in prevention and early intervention. Treatment occurs mainly after the illness is set in. And if we could, mental health treats people at the bottom of the cliff when they've fallen over it. We need to pay greater attention to stop people from falling over the cliff in the first place. And I've just got a little chart up there saying what we should do about resource allocation. we should reinvest to save. We like to try and get less spending on acute at the hospital end and get it into prevention through community mental health services, child and adolescent, psychosocial supports, primary mental health care. And if we did, there would be less costs for DSP and carer payment. And another way of putting it is to bend the cost curve. So the yellow curve is the cost curve I'd like to see in mental health. The green curve is the way it is at the moment. Access to services is also low. I've already mentioned the maldistribution of the workforce and the Medicare effect. Also, carers and families need to have a much greater role. The fact is that families are the ones with the lifelong commitment to and deep knowledge of the person with mental illness. The system does not work very well about harnessing that tremendous input. And also, persons with lived experience, consumers, should be involved in the solution. Mental health for us, not without us. An interesting question for economists is whether personal budgets would help out here. Indigenous, it should be one of the closing the gap targets. It's really obvious. And there needs to be a socio-economic wellbeing framework which picks up on the fact that, white fellas treating Indigenous people may not be fully attuned to the culture of the Indigenous population. Suicide, I won't go into that, but it's too high. It could be reduced. It has not been reduced. I'll just make one point. Anyone who attempts suicide should be counselled and monitored after that. I'm afraid that's the best predictor of suicide. Previous attempts. Someone I know tried to commit suicide a few weeks ago, somewhat well-known person, and they told me after they got out, no one followed them up for 4 weeks. They got a call 4 weeks later. Workplace, I just mentioned that in passing again. Obviously, it's a big workplace problem. There are some detailed suggestions for that. Better work design, more flexible hours, etc. Promote early help seeking, build a good work culture, resilience, support recovery, increase awareness of mental illness. I'm just skating across that topic. New technology like e-health is becoming important, and it gets to people in remote areas and in poor areas and so on. And then there's a huge challenge in getting the workforce right, the ageing, diminishing workforce of mental health workers. Poor data on outcomes. There's not much evaluation activity going on. So I've just mentioned that reform is to let people lead as fulfilling a life as is possible. The potential gains are large. The cost avoidance possibilities are considerable. The workforce participation possibilities are great. And so there is a possibility, more than that, that it could contribute more than many things to better productivity. Now, on research, NH and MRC, mainly medical, mental health gets a low proportion of medicine, and then economics generally and mental health service provision receives little. I've just listed, basic areas of research: determinants, cost of the economy, productivity impact, public and private provision and funding, market structure, demand, supply, prices and incentives, insurance, choice and competition, labour supply, carers, cost-benefit studies, geographic distribution of services. Just on the resource allocation, there's massive issues: prevention and early intervention versus treatment versus research, primary, secondary, tertiary, different kinds of mental illness, public, private, non-government, health-based treatments like hospitals versus things like housing and employment, geographic and regional, different parts of the workforce, and the priority of mental health spending versus other spending. So as I said, there are many interesting research issues for people to dig into. For example, there's, just if you started at the very beginning on day one and asked, well, what about private insurance as a solution? Well, as with disability more generally, and especially genetically driven disability, but even more so with mental health conditions, private health insurance markets obviously have a struggle. They really have a struggle to cope with mental health. There's a major adverse selection issue. There are some potential moral hazard problems also. And then there's also the long cost tail problem, which is a bit of a problem here. I know it's a big problem in the US, but the insurers like to somehow get rid of those big, long tail cost things by excluding people from coverage. I think that's a rather hot issue in the US at the moment. So given what I think is a fairly obvious looking market failure, and I think this morning Carol perhaps touched on, people with at the bottom end of the income distribution section don't have that much choice, even if people did have a choice of paying for private health insurance. They wouldn't really have the resources to do it. So we then get into the question of what forms of government intervention would be optimal, what incentives would be right, what forms that would take. Is it subsidies to get private insurance? Is it direct help and so on? And also, as I just touched on at the beginning, another basic question is pricing for mental health. The standard approach to pricing, as I mentioned earlier in health, is to set some sort of price per treatment, but it works poorly given the asymmetric information situation between the consumer and maybe the carers and the person providing the treatment, all the principal agent problems, the monitoring questions and so on, together with the huge uncertainty about the cost of treatment, means that this almost standard pricing solution that we trot out as a quick answer to questions about resource allocation and incentives in the health system don't work terribly well, along with under-treatment and shirking and skimping and all that kind of thing. I actually think in mental health there's a lot of really interesting research questions to undertake. So I do think it's quite a good field to do research in. In a more applied way, there's a need for far more cost-benefit studies. We need to look at the fee-for-service system, activity-based funding I've mentioned. We have the NDIS scheme at the moment, and that's really interesting. It goes for choice. It's trying to expand supply, get some competition and new markets. Very interesting. And mental health is in it, sort of, but if you read the press, if you read other things I've said, there are a lot of worries about the treatment of mental health. A lot of mental health is being transferred to the NDIS, and it is really clear that the way things are going at the moment, an awful lot of people who are getting treatment at the moment are going to miss it under the transfer to the NDIS, no matter how worthy it is for people who get full and proper treatment. Harper has talked about it, choice and competition in the provision of public services. The PC is doing a reference on that. There's the question of an investment approach to the provision of welfare services, pioneered strongly in New Zealand, the idea that you look at a person, their costs, their needs, their lifetime needs. How do we go about investing in them? That's an interesting approach. Has some pluses, one or two minuses. And then, of course, we have the federalism issues. I don't want to blame them too much. There are quite a few other problems, even if there was cooperation. Okay, now, final point, as I always say when I'm a quarter of the way through my speech, my final point is that there's this wider question of the mental wealth of the nation, and Malcolm Turnbull has been promoting this idea, the mental wealth of nations, the OECD in How's Life. The Treasury has talked about well-being and so on. But what I'm interested in is getting mental illness, mental health and mental wealth on the economics agenda on the basis of the argument that there's a big payoff to an investment and a reorganisation here. And I think it would be a good idea to have a Productivity Commission reference to get it onto the economic reform agenda. And there we have Malcolm Turnbull. The mental wealth of a nation is as important as its physical wealth. Thank you.
Well, thanks very much, Alan. We'll now move into our panel responses. So please come up, panel. Okay, well, I think best if we just take it in the order which is on the printed program. So our first panellist is Professor Deborah Cobb-Clark from University of Sydney. So Deborah.
Is this on? Yes? Okay. Are you going to give me a signal down there?
I'll give you a signal at maybe 6 and then
Yeah, that sounds good.
a big wave at 8.
Yeah, I can talk forever, so it's worth getting the commitment device in place first. So I just want to start by thanking Alan for what was a very impressive and interesting overview of the issue, and also thank him for his long-standing leadership in this area. He's been at the forefront of really promoting the importance of mental health and poor mental health as a pressing social and economic issue. And what I wanted to do today is to just expand on 2 points that he's kind of made in his presentation, and drawing on some new research that that we have in Australia, which colleagues and I have been doing, funded by the Australian Research Council, actually, not the NHMRC, through a series of discovery grants and a Centre of Excellence that we have. So the first point that I want to make is that in Australia, poor mental health is being a pathway through which disadvantage is being passed from parents to children. Alan referenced the fact that disability, the disability support pension, a large component of that goes to individuals who have mental health issues. And that component has been increasing over time. In the early 2000s, it was about 20%, and we're now closer to a third. So I want you to do a thought experiment with me, and I want you to imagine a birth cohort of Australian kids that were born in the last quarter of '87 and the first quarter of '88. And just to help you fixate on that, they're staring at their 30th birthday. And I want you to think about what the outcomes for those children are if their parents were primarily being supported by the disability pension as a result of mental health issues. Now, the good news is that very few of those children are in that situation. Less than 1% of that birth cohort had a primary parent who was on the disability support pension for mental health-related issues. The bad news is that the outcomes for those children are much worse. And we did 2 comparisons. So we compared the outcomes for those kids to children whose parents had no income support whatsoever, as well as to kids whose parents might have had other forms of income support, but didn't have any DSP for mental health reasons. So at age 26, if your parent was primarily being supported by the disability pension for mental health reasons, you're somewhere between 1.6 and 2 times as likely to be receiving some form of income support yourself. Not surprisingly, there's a high correlation in receiving disability support pension for mental health reasons. So for children whose parents were on DSP for mental health, they're between 2.6 and 4 times as likely to be getting that same payment themselves at age 26. One of the things that I find particularly interesting about looking at these data, and I should say this is coming from the Centrelink data. Well, we call it the Centrelink data, but it's essentially the administrative data, which is housed by Department of Social Services. We're very fortunate to have administrative data which now give us a long intergenerational perspective. These data go back all the way to 1995, so we can observe what's happening to these kids as early as at about age 8. This pathway onto income support certainly operates through a high likelihood that you're going to receive the same payment that your parents were receiving. But it also operates through other payments as well. So in particular, I just want to make note of the CARES payment. If you are one of these children who grew up with a parent on DSP for mental health, you're between 6 and 15 times as likely at age 26 to be receiving a CARES payment. Okay, and I'm going to say that again, 15 times, 1,500%. It's an extraordinary relationship between having that experience as a child and as a young adult already being in receipt of a CARES payment. The other thing that's interesting is that it makes you more likely to be receiving New Start at age 26, somewhere between 1.4 and 1.9 times as likely. And that happens to be exactly the same intergenerational correlation that we see in unemployment benefits itself. So another way of saying that is that we have high correlation between the unemployment of parents and children, but it's the same correlation for the kids who grew up with parents receiving disability support pension. The second point I want to make is that poor mental health in Australia is a pressing labour market issue for all kinds of reasons, but in large part because of the large number of employees who are suffering from common mental health issues. So this in Alan's chart is the light blue area, which is sort of the biggest. It's a group of individuals that we actually know a fair amount about because we're fortunate to have HILDA data, which has been collecting mental health questions about every individual in the household in Australia for now going on 15 years. It's not the best data source to be looking necessarily at the severe end of town, but if you're interested in what's happening to people who are suffering from common mental health issues, it's a pretty good data source. What we have done in a series of projects is demonstrate a couple of things that I guess we've sort of known innately, and that is that there's a simultaneous relationship between poor labor market outcomes and poor mental health. That is to say that poor mental health leads to poor employment outcomes, and poor employment outcomes lead to poor mental health. And you can, and I'm prepared to sort of take a stand that it looks like causality in both directions. We can also quantify the extent to which common mental health issues lead to increased presenteeism. It's about 5%, which is actually quite large because absenteeism rates particularly as captured in HILDA, are particularly low.
6 minutes, Deborah.
People are 6 times as likely to report that they are struggling to either do the work that they want to do or be productive at work as a result of having a common mental health issue. And in fact, these are OECD numbers. Between 36% and 56% of those, depending on the severity of the mental health issue, are reporting that they're having trouble being productive at work. The overall cost that lost productivity, and this is just a component which is the reduced productivity of people who are actually in employment, which is a small fraction of the problem, is somewhere between $11 and $12 billion a year. So as a consequence, I think there's a couple of things that we need to be particularly focused on. Mental illness is a family issue, and policies need to recognize that while we're struggling to deal with the individual who suffers from mental illness, this is having an impact, particularly on children in those families. The second is we need closer integration between employment and health sectors. The employment sector tends to focus on employment issues, not taking into account mental health, and the mental health sector focuses on mental health issues, not taking into account the importance of the employment relationship in supporting recovery. And then if there's, I think that the value in focusing on employees is that it gives us another policy opportunity that we haven't really addressed, which is working through employment relationships and the way that we organize work to attempt to reduce the pressure for mental illness. And the one thing that the HILDA data make crystal clear is that if there's a magic bullet anywhere in that, it's reducing job stress.
Thanks, Deborah. Our next panellist is Dr. Jeremy Samet from the Centre for Independent Studies. I've invited Jeremy because he's done some really interesting policy-related work on other health issues in recent years. So, Jeremy, welcome.
Thank you, Paul. Yes, as Paul says, my expertise is in health systems in general rather than in mental health specifically. However, I have done a lot of work on the mental health related field of child protection policy. So this is to say I haven't done any detailed work on the policy challenges associated with mental health services in Australia. Nevertheless, what I'd like to do today is to try and make some general observations in response to Professor Fels' presentation, drawing on my experience working on problems in both the health and social services sector. Firstly, I want to examine the links between child protection policy and prevention of mental illness. And then secondly, and admittedly more speculatively, I want to sketch a hypothesis I have about mental health policy. Now, of course, I'm broadly aware of the contours of the debate surrounding mental health service provision, and by definition, hypotheses are yet to be proven. So what I'm going to offer today, at least in the second half, it comes with that explicit proviso. I'll be raising questions for discussion and potential further inquiry and research, rather than stating firm conclusions and recommendations. And I guess in a sense, I'm using today as a bit of a tree shaking and flagpole raising exercise. But firstly, I'll stick to what I know. There are currently over 45,000 children in Australia living in some form of state-funded foster, kinship or residential out-of-home care because they've had to be removed from their parents due to welfare and safety concerns. Now, almost all of these children in care have what is called high needs. That is abuse, neglect and trauma-related emotional, behavioural and psychological problems that require some form of professional counselling or social support services and assistance. The level of need in the out-of-home care population has reached the point that there's now serious policy discussion about the need to professionalise the care sector. This is to say that children's problems and behaviour is so challenging that it is not enough for children to live with a normal foster family, but instead need full-time professional carers. Now, this is already happening in an alarming way. The most severely disturbed and antisocial children cannot live safely in a normal foster family and live instead in what's called residential group homes with full-time paid professional staff, and which often have a very strong psychiatric focus, especially in what is known as secure facilities. Now, these residential group homes are, for want of a better term, the modern day institutions. More than orphanages, they are more like the mental health asylums of old, and the number of severely disturbed Australian children living in residential care has more than doubled over the last decade. In the mid-2000s, it had dipped under 1,000. We're now over 2,000 kids currently in residential care in Australia. So why are there tens of thousands of Australian children in care suffering from mental illnesses which include depression, hyperactivity, ADHD, anxiety, post-traumatic stress disorder, sexual deviance, conduct disorder, aggression, delinquency, poor peer relationships and social functioning? The answer, which I've documented in my book, which is called The Madness of Australian Child Protection, is that these children have been severely damaged by Australia's flawed child protection policies. Since the 1970s, child protection policy in Australia has moved away from the traditional emphasis on rescuing children from harm and removing them into care in a timely fashion. Nowadays, in every state and territory, child protection authorities practice what is known as family preservation at almost all costs. This means that every effort is made to keep children, even with highly dysfunctional parents, which means that they are exposed to prolonged abuse and highly damaging abuse and neglect. Moreover, when children are finally removed as a last resort, many are further damaged by experiencing highly unstable foster care and repeat breakdowns of family reunifications, because the ultimate goal is always family preservation and family reunification. Now, the profound harm, and in my opinion, the system abuse that children suffer in and out of care could be avoided if more children in Australia were adopted, if they were removed earlier and permanently and achieved permanent stability by being adopted by new families. But adoption is a taboo subject in Australia, and hence there are only around 100 adoptions from care each year, and that's despite the fact that of those 45,000 children in care, 2/3 of them have been in care for longer than 2 years and are very unlikely to ever be able to go safely home to their parents. Australia's child protection system, which does too little and too late to rescue children and actively harms them by exposing them to maltreatment at home and instability in care, in my opinion, is nothing less than a mental illness factory. This is a major place in the country where the genetic and environmental factors explained in Professor Fels' presentation hit the road to create mental illness, and that also creates gross social inequalities across the community, because the outcomes in life for children who are caught up in the system are generally appalling. Now, I agree with Professor Fels about the cost benefits of prevention rather than treatment at the bottom of the cliff, and bearing the associated costs of mental illness across the whole of government. And I would assert that the best form of mental illness prevention we could invest in would be to do something about our flawed child protection systems. What I've also learnt by studying the child protection system and about how and why government-funded service sectors operate the way they do is, I also think, relevant to the mental health policy debate. What we have in the child protection system is a family preservation-based model of care which, measured by all objective outcomes, doesn't meet the needs and serve the best interests of the children who the system is meant to protect. Now, despite the weight of evidence that you can compile to show that the system is inappropriate, the system is very, very difficult to change. And one of the major reasons for this is that the system is really a political economy.
Jeremy, excuse me.
Sure. Which, like all government service sectors, is prone to provider capture. In child protection, this means that we persist with family preservation because of the vested interests and political influence, particularly of NGOs that receive millions in government funding to provide family support services for dysfunctional families, and who also receive large amounts of funding to provide out-of-home care packages for kids when they finally end up in care. It's also underpinned by strong ideological convictions of the experts, professionals and stakeholders in the field. And so what we get in the child protection debate is a belief that child removal does more harm than good, and therefore the family preservation model remains sound. And this view continues to prevail in the policy debate, again, despite the weight of evidence. Now, I just want to speculate quickly on how these political economy, provider capture and ideological factors might also be relevant to mental health policy with respect to deinstitutionalisation, which has been the major policy change, I would say, over the last 40 years. Now, obviously, given what we know about what happened in the institutions, there was a reason to try and develop a more humane, community-based model of care. But I suspect that the story of deinstitutionalisation was more complicated. I don't think it was coincidental that this coincided with the deinstitutionalisation, which started in the 1980s in Australia, started in the 1960s in Britain, coincided with the start of free hospital care under Medicare. And I think that due to the impact of rising cost of health onto state budgets, I think that state governments perhaps looked more favourably on closing mental health facilities as a cost-saving and cost-shifting exercise. So states didn't have to bear the cost of the keep of the mentally ill. They could shift the cost, say, onto the federal government through the DSP, as we've seen in the presentation. I've also been told, anecdotally at least, that in New South Wales, that the argument that community-based care advocates mounted about community-based care being less costly was influential with policymakers at the time. Now, if this is right, then maybe the mental health system is an example of the inverse care law and an example of the reverse insurance, which often happens in public health systems, which basically means that the least serious and least costly health needs of the community are often over-subsidised because often for political reasons. Politicians like to gain the largest number of votes for whatever government funding is available, and the most serious needs of the health needs of the community are under-subsidised because the voices of that minority and the votes of that minority count for less. What I also suspect perhaps is that the ideological commitment to the community-based model of care from experts, professionals and stakeholders in the sector is similar to what I've seen in relation to family preservation in the child protection sector. The ideology says community care is best, regardless of the evidence that might contradict this and which might suggest the community-based model of care is suboptimal for those with severe mental illness. Now, very respectfully, I just want to quickly try and round off. I want to challenge Professor Fels's idea that we just simply need to invest more in community-based prevention of mental illness. He suggests that we need to reduce, reallocate and reinvest resources away from high-cost hospital treatment for mental illness, which is the ambulance at the bottom of the cliff. Now, this sounds intuitively correct, but it also sounds like the argument I've heard about child protection, that there are too many children in care because we don't do enough investment in early intervention and prevention of child abuse. But this is not right, and the counterintuitive truth actually is that we do too much and too prolonged so-called early intervention to try and keep kids with their parents. In other words, the model of care is inappropriate and is not meeting the needs of maltreated children who end up in care regardless of experience, and after experiencing prolonged abuse and harm. Now, quickly to close, and I'll leave this for discussion, I wonder if something similar isn't occurring in mental health, and that the severely mentally ill end up in hospital or alternatively in jail or homelessness because the community-based model of care is incapable of meeting their needs, because it is impossible to provide the intensive level of care, support and management required in an affordable manner in the community. Now, I know that this, how these social policy debates tend to go down. I can already sort of hear the chorus of execration, which is that not only do I want to, adopt out kids, steal kids from their parents and adopt them out, but I also want to, round up and lock up the mentally ill. But if what I'm saying does go against the grain of what is the conventional wisdom in the policy debate, I don't want to denigrate the work that has aimed to reduce the stigmas that used to be associated with mental health, mental illness, and that has tried to ensure that people with less severe mental illness get access to treatment and address their issues. But I think we need to be aware that by focusing on the less acute end of the spectrum, by broadening the net of mental illness and focusing on prevention across the whole population, we might be losing focus on some of the biggest problems and more difficult issues, which I think may be the appropriateness of the community model of care for severe mental illness, which in practice may be an example of the inverse care law. Thank you.
Thanks, Jeremy. Our next panellist is Frank Quinlan, Mental Health Australia.
Thank you, and I'm going to try and see if that's a helpful first sign. I'm just going to see if I can bring up my presentation here. Can anyone see my mouse? There it is. I almost gave away my gag then. Thank you very much for the opportunity to be part of this panel presentation today, and I'm going to try and constrain my comments as a response to Alan, though Jeremy's provocative comments obviously I think helped to foster some of this debate. I did do a little bit of research, hence the next slide. I did do a little bit of research this morning. I put the hashtag up ACE 2017 because I like to tweet a bit about where I am and what I'm doing. So I did a search on ACE 2017. I don't know if you did that before the conference, but when I brought up that this was the first image that I found, and it's the Arnold Classic Europe 2017.
We don't really measure up, do we?
No. Well, I did wonder what I was getting in for, because I noted on the program too that there's going to be a talent quest as part of the this conference of economists, and I thought that perhaps this was an impression of that talent quest, but apparently no. But certainly thanks very much to Paul for all the work that you've done to bring this session together and the influence over the program. I think it's a really valuable conversation. And thanks to you, Alan. It's a privilege to follow you on the platform, because you've been a giant of thought in this regard, and I think there is, in fact, a lot for us to think about. I use this slide quite a bit in my presentations, and it goes to a bit of a reflection about, I guess, linking correlation and causation a little bit, which I think is one of the problems that we have in this discussion. This was painted on a rubbish bin outside Old Parliament House some time ago, and I took a photo of it right near the Indigenous Tent Embassy that's there. This has been a really persistent problem for us, and I think that mitigates against the idea that there are simple or quick fixes to this problem, because I suspect if there are simple or quick fixes to this problem, they would have been found all that time ago when the Richmond report heralded the notion of deinstitution, when Brian Burdekin wrote about these issues, when John Howard made comments that were in fact very similar to the comments that Alan cited from Prime Minister Malcolm Turnbull recently about the need to invest in mental health and the challenge of doing so. I often say that I think part of the problem is that we approach the challenge as if we have a mental health system. And I think that's a flaw, a fundamental flaw in our argument. And I think you touched on that a little bit, Alan. We have a whole lot of services and programs, certainly, and they're quite atomised, really. Some relate to each other very well. Some relate to each other very badly. Mostly where those independent programs relate to each other well, it's because good people in those systems are making bad policies work in spite of the bad policies. And so we do have this sort of fragmented environment, and I think that's easy for us to cloud our thinking. And I think we only need to consider the breadth of Alan's presentation to really reinforce that notion that there is not a single idea of mental health reform. There are a whole lot of ideas around mental health reform that could be usefully pursued in their own right. And I intend to just touch on a couple of them. The Human Rights Council of the United Nations recently released a paper just in the last couple of months that looked at the notion of mental health from a global perspective. And it said, amongst other, I actually really commend the report to all of you because I think it did lay out a very comprehensive agenda for mental health reform, and it's quite useful. But it says that nowhere in the world really does mental health enjoy parity with other systems. And I think one of the questions that I would have, and only partly triggered by Jeremy's comments, is I do think there is a fundamental question about the quantum of our investment and whether our investment is actually fit for purpose. The example that I sometimes give is that if I go into a GP with an inner ear infection, the GP, based on the evidence, will make a number of decisions. The GP will first determine what antibiotic I might be prescribed, because some antibiotics are better for ear infections, others are better for other kinds of infections. So there's that sort of first decision to be taken. The second decision that the GP will make is about what strength that antibiotic should be at in order to achieve the likely impact that the evidence would suggest. And the third is what's the duration of that treatment and how long I should be on that treatment for in order to give the antibiotic the appropriate effect. And I think the evidence that we have in the mental health space is pretty scant relating to all three of those decisions. It's pretty scant about saying if I present to a GP or a psychologist or a psychiatrist or to another care worker in the system, the evidence is pretty scant about precisely which intervention might best suit my circumstances. It's even more scant then about what the strength of that intervention should be and what the duration of that intervention should be. And I think we'd be, across the vast range of issues that you presented, Alan, I think we'd do well to concentrate down onto those smaller areas to determine what the evidence might say. Because we don't blame the antibiotic. We don't say antibiotics are useless if we apply the wrong antibiotic or if we don't take it for long enough, or if we build resistance by applying it in inappropriate circumstance. We don't blame the antibiotic, we blame the strength of the intervention and the duration of the intervention. I think we could do some thinking about that in this space. The Human Rights Council also suggested that states must invest appropriately in this space, and noted that mental health spending stands at less than 10% of spending on physical health. So there is an equity issue and, again, a strength of dose issue. In the 2017 budget, just to reinforce the comments that Alan has made really, we notionally spend about 5% of the total health budget. And we seem to have been stuck at about 5% of the total health budget being spent on mental health issues since the late 70s or 80s, when there's in fact been quite substantial investments. And the substantial investments that we've seen since have only managed to keep us at about that 5% rate. Notwithstanding the fact that mental illness is about 12% of the disease burden and about 24% of years of life lost. And I'm not suggesting for a moment that there's an exact correlation, that we could take either the 12% or the 24% and say that that is notionally should be our percentage investment of the health budget. But I do think it at least prima facie presents the idea that we may simply not be investing enough. I also want to just draw attention to the idea that Alan touched on in his presentation, that we are often focused on the medical aspects of mental health treatment, the psychiatric interventions and the psychological interventions, including the pharmaceutical interventions. The Human Rights Council recently reported that psychosocial interventions, not medication, should be the first line of treatment. And this goes to the notion that our interventions in the mental health space are, I think, inextricably tied to a lot of our social issues. And you know, our opening presentation today, I think, gave us, again, a very deep insight into the idea that our mental health is tied to a whole range of economic and social and cultural circumstances, in addition to the genetic and medical factors that we take for granted. We are used to the idea in our health, in our general physical health, that we can all do something to improve our physical health. We can all exercise a bit more or eat a bit more healthily. We all occasionally can have acute injury or illness. We can pick up a bug and get sick for a little while and either rest and get over it or do the intervention that the GP recommends and get over it and overcome an acute injury. Or we can all from time to time, dependent on a range of circumstances, contract an illness that might be considered chronic and ongoing, whereby we treat it in an acute phase and then manage it in an ongoing phase. And I just think it's not very long ago since the asylums and some very powerful drugs were really the only response we had to mental illness. And I don't think we've yet developed in that very short period really of mental health treatment. I don't think we've developed a very sophisticated idea that we can all experience the same sort of provisions in relation to our mental health, that we can all do things to improve our mental health and resilience. We can all have acute injury from time to time, and in some cases certain conditions can become chronic even if manageable. And I just again wonder whether our sophistication in relation to our thinking about mental health hasn't developed far enough for us to consider those issues. And in terms of wondering why, and I guess this is the fundamental question that I would sort of leave hanging, I think the question of discrimination and stigma is fundamental to many of the challenges that we face. So the question really of why, given the evidence that Alan presented about the potential of economics to achieve a huge impact on the national productivity and on national GDP, if only we were to study and apply the right principles, it's interesting to ask why that's not occurring. And I think many of the questions that we come down to, both about the allocation of resources in our budgets and the allocation of efforts in our scholarly endeavours, come down to this notion that I don't think we've yet overcome the idea that discrimination is both a cause and a consequence of mental ill health. The Human Rights Commission, when they, at the United Nations, talked about a revolution that's required in mental health. And I think this is the one thought that I'd try and leave us with. I think the evidence that you presented, Alan, is overwhelming in relation to the case that has been made for significant mental health reform. And it troubles me, and I honestly lie awake at night wondering why we haven't had more success in turning that case into action. That case has been made in different ways and in different formats for a long time. And the strengthening of the economic case around the need for mental health reform seems to me only to be part of the question, that our, in that sense, economics is a necessary component of the reform equation, but clearly not sufficient. And I wonder aloud, really, what it is about this revolution that will be required in order to actually achieve the sort of reform that we're talking about. What is the revolution that's required in our thinking? What is the change of heart that is required in relation to discrimination and stigma associated with mental illness? Because I really feel until we overcome some of those challenges, the economic case is unlikely to achieve all that we want it to achieve, as necessary as it is for us to be making that case. We have an opportunity, I think, in the current political environment, and it's impossible to separate out the politics from the facts. We have a current Minister for Health who I think is deeply committed to many of the notions of that we'd be concerned about in the mental health space. The Minister has spoken personally about his own lived experience and family experience in mental health, including the experience of his mother ending up in an institution in Goulburn related to her bipolar illness. So I do think there is an opportunity for us, but as I've tried to say, I think somehow we need to find a better way of marrying the economic case and the economic arguments with the personal and human arguments, because without that human factor, I think we're unlikely to achieve the sort of reform that we're looking for. So I might leave it there.
Thanks, Frank. Well, our final panellist is Richard Freeman. Do you want to come up here? That's probably easier, Richard. Yeah.
So I have three comments, and the first is what economists can bring to the discussion, and I'll be very clear about where a lot of the things I've read and some of the things said by the panelists just ignored this particular component. If we're going to change policies in any rational way, we cannot be talking only about the size of the problem, the burden of the disease, the fractions of more money being spent on physical things than others. It has to be about if we shifted money to mental health, do we have actual programs that will deliver benefits that exceed the costs? Everything has got to be put, it seems to me, in a marginal benefit cost position. The Alan and Deborah and Frank all showed us the evidence that this is a big, but if we don't know what to actually do with a particular program, it doesn't mean spend more money on it, shift money from other things. And I think that occurs on several levels. First thing I started looking at was, okay, how much money are we spending on research on mental health as opposed to treatments for mental health? And there are some complaints that not enough is being spent on research on mental health. And I just came, where's the evidence that more money, that here is a particular research program that would actually tell us how to better deal with the problem, either reduce treatment costs or at least improve the benefits that come out, or so, et cetera. Second, and then for the research on mental health, I think almost all the statistics that I saw are leaving out the huge expenditures that we're doing, every country's doing, in the brain science. That has to be the underlying super basic science going on here. I'm not sure how that connects to the more, I call it practical research things that one is concerned about, where you can deliver some benefits to some people at a given period of time. But somewhere the brain science expenditures should be brought in, and brain science things, maybe there should be more focus there on how do you doing your basic science, and where is that going to lead 5 or 10 years down the road to treatments, et cetera. There's a lot of it seems to me, pretty good estimates of, okay, how much do these treatments cost? What is the amount that one is spending? I looked at the U.S. Data. They said we're spending about 1% of GDP on treatments for mental health, and a lot of it depends, as Alan sort of pointed out, how do you count substance abuses? Where are they counted in this phenomena? So, but in Australia looks the same ballpark, and so do a bunch of other countries. When we go to looking at the benefits, we cannot be talking about how much we could save by having lower cost programs or more efficient programs. We have to take account, which Deborah brought out, on what's the effects on the economy in terms of productivity, absenteeism, unemployment, et cetera, et cetera. So I think the numbers get much larger when we talk about the social costs, and ultimately any policy changes have to be brought in. There really are big benefits there, because the benefits outside of what we're spending from our healthcare systems are quite a bit larger if we can cut things down. That was, Alan stressed that. But the missing part, I thought, in the discussion has to be about a program that we can show, if you do this policy, and that's what should be tested, different policies, so that they can have a positive marginal benefit over marginal cost. Just having the numbers there tells us that it's a big problem. Second comment, I've been doing work, and I'm here actually to give a talk next week on robots. And one of the big things everyone sees, robots, artificial intelligence, you have these headlines, all the jobs will disappear in 20 years, 30 years, 50 years. A third of the jobs will, everyone has seen them. And then you start thinking about, oh, let's say that that's partially true. Now, what are people going to be doing in their mental health if they don't have a useful activity to do in society? And I don't know. There's a couple of hypotheses you can have. Very little research about this. We certainly know that people who lose their jobs have bigger mental health problems than people who don't lose their jobs. But that's in a world where I lose my job and everybody else here is working. So I relatively feel bad. But what happens if we all lose our jobs and the income distribution problems are worked out, so we get a share of what the robots are making? Are we going to be happy, sad? Are we going to feel completely lost? And I wonder about the things about the mental health problems that indigenous people have, because they don't feel productive in the society because of the links and so on. It's very possible we'll have a very unhappy population of people sitting around saying, okay, I'm getting my check from the government as my part of the ownership of this great new technology, but what do I do usefully? And I ask some young people, what would you do? And they say, play video games. And I keep thinking, well, maybe you do that for a few years, and then you might find other things to do. So I think there's actually an interesting research agenda that is not being thought of at all, and where you could parlay some more money if this robots thing is and it's, you know, it's certainly getting headlines. What's it going to mean for people's mental health in the future? My third comment is just how to bring economics into this in a much more serious way. And Alan basically said, oh, economists are not really thought about as part of the thing. Money goes to medical people. Well, I'm doing a project now which we bring the economics in on a different area. It's pollution. Pollution has effects on health in many different dimensions. Economists have shown very nicely that it reduces productivity. If you're in a polluted work environment, your productivity is lower. If you're a woman bearing a child in your belly and you've got pollution out there, the kid is born with brain problems. I mean, they don't do as well in school, and as far as one can see, it's causal kind of phenomenon. Well, so what do economists do in this kind of a world? There's just a lot of people measuring the costs, and I think our job or function should be to say, okay, let's devise a program, and now let's test it with the marginal benefit cost things, and then we go and we yell for the program. You want to know what to do? Here's a program that is tested, but done scientifically well. And my view is the only way that can be done is if we are paired with be it psychiatrists, be it doctors. In our work on pollution, we work with engineers, because if you're going to clean up the air in a building, you got to know about the airflows and this and that. You work with architects also for the building side. You work with people who are studying brain things, because how the pollutants get into the brain is absolutely fundamental into some of its bad effects. So I think the right thing for economists to push is that we be part of the solution, because we will be solution oriented. And no insult against economic theorists and econometricians, but I think it's fundamentally more of an applied economists who understand benefit cost things. The people I work with who are not economics trained do not understand those things. They make decisions in a different way than we can offer. That's my comment.
Thanks, Richard. So it's lunchtime, so I think we're going to have continuing discussion in other forums after this. The session, we hope, will be available on the Economic Society website. So if you've enjoyed it, you can point people towards that. And Alan's talk, I believe, will be published in the Economic Society's journal, Economic Record, at some stage. So that also, I hope, will be a basis for continuing discussion, of these issues. But thanks for all our speakers, all our panellists, for their contributions today. And I hope this is going to stimulate further research and further, discussion in policy circles, about how we can fix the huge problems in the mental health system, for the benefit of the people who suffer from mental illness. Promote discussion and research about these issues. So let's thank our panellists as we head off to lunch.